My name is Shruti Katari. I lead industry initiatives for Blue Shield of California, where we're focused on scaling and sustaining healthcare innovation through industry collaboration and policy movement. So today, we've intentionally brought really different national and local stakeholders to discuss how California can realize the vision for primary care as a common good. And this was set forth in the recent NASEM report, Implementing High Quality Primary Care. So today's focus is going to be on behavioral health integration. For primary care to be truly foundational as a foundation of a healthy society, we need aligned payment models, and they really need to incorporate behavioral health integration. So we hope this discussion can be a stepping stone in that right direction. And in that effort, I want to just quickly go over our speakers. We have a power list of folks here for you today. We have Gil Addo from Rubicon MD, Nina Bourbon from Blue Shield of California, Jessica Cruz from the National Alliance on Mental Illness, Christopher Kohler from Milbank Memorial Fund, who are also our partners in hosting this event. So thank you, Milbank Memorial Fund, and Karan Singh from Headspace Health. If the panelists could come up now on screen. Thank you. So if you could just tell a little bit more about how you're supporting behavioral health in California. Maybe Jessica, we'll start with you.
Hi, everyone. I'm Jessica Cruz. I am the CEO of NAMI for California, and we support families and individuals who are impacted by mental illness.
Thank you, Jessica. Nina?
Yeah, hi, thanks. So there's two different ways I would say I'm supporting behavioral health in California. At Blue Shield, we're looking at payment models that support the provision of high quality behavioral health care for all. And we're doing this by what we call reimagining our relationship with behavioral health providers and developing new models of payment for them, as well as supporting advanced primary care where people can both receive and deliver whole person care. But I'm also a family doctor, and in my primary care practice, I continue to assess and treat mental illness. And I also, of course, struggle with the inadequate referral network that we have when I need to refer out for more complex treatment.
Hi, thank you guys for having me first and foremost. My name is Gil Addo. I'm one of the founders and CEO of Rubicon MD. What we do is we provide virtual specialty care to support primary care organizations, and specifically within the behavioral mental health space. We provide collaborative care, collaborative management through virtual psychiatrists, as well as potentially staffing care managers to support primary care organizations across the country. We also provide access to a network of specialists on the physical health side as well. And so within California, we are primarily in Northern and Central California, but have a growing presence in Southern California as well.
Hi, everybody. Nice to see you all. I'm Karan Singh, the Chief Operating Officer at Headspace Health and co-founder at Ginger, which merged with Headspace last year really to form a comprehensive mental health and well-being platform that spans pretty broad spectrum of need, all the way from mindfulness and meditation tools to on-demand care via coaches, therapists, and medication management via our psychiatrists. And so, I'd say we're supporting the California population in a couple of ways, both directly to consumers, but also by unlocking access to affordable care through a lot of partnerships with close to 3,500 employers, a variety of different health plans, and increasingly health systems where we're acting actually as a wraparound resource, behavioral health resource to their primary and specialty care teams. So incredibly excited to be here and chat with this group.
Hi, folks. I'm Chris Kohler. I'm president of the Milbank Memorial Fund. We are a national health policy foundation. Our work around primary care and behavioral health is specifically, we work with state health policymakers, educating them on how primary care has to be the absolute foundation of a high-performing delivery system, helping them understand what high-quality primary care is, including behavioral health, and then identifying policies that they can put in place to help make that happen. It's great to be with everybody.
Really, to kick us off, I would love to hand it to you, Chris, for some opening remarks.
It was really an honor on my part to be able to serve with the National Academy of Science, Engineering, and Medicine around implementing high quality primary care. Next slide, please. And the National Academy of Science, Engineering, Medicine really was commissioned to say, okay, if the challenge of implementing, we realize the value of high quality primary care, how do we actually make it happen in the US? First thing we had to do is to focus on what this definition is of high quality primary care. I want to call attention to what the committee came up with, this notion of whole person, integrated, accessible, equitable care delivered by teams. That teams notion is really important. They are accountable for addressing the needs across a variety of settings, not just in the doctor's office between 1 and 4, and through sustained relationships with patients, families, and communities. And when we say whole person, this is what we're talking about. Whole person health focuses on well-being rather than the absence of disease. That creates enormous opportunities and space to work on the behavioral health components and include that into a definition of comprehensive primary care. Next slide, please. These are the objectives that we came up with. We really tried to crystallize what are the things the most important things you have to do to implement high quality primary care. Hopefully these do not come as surprises to you, but they get to payment, they get to ensuring access, they talk about workforce, and they talk about the role of digital health, and then they talk about accountability, improvement over time. And there's a set of recommendations associated with each. Next slide, please. And what I want to call out is how this work around primary care relates specifically to the evidence of what it takes to integrate behavioral health into primary care across a spectrum of acuity. A number of our introductions talked about that. So, and these are tied to the recommendations that the National Academy put in place. So I'll begin at the top left and go around clockwise. You need payment models that can support primary care behavioral health integration. And we've got some specific ideas for what that is. It clearly cannot be just individual claims to individual providers. You need some per capita ways that allow for provider teams to be formed that can provide behavioral health. You've got to have team-based care that's co-located or coordinated, and that can vary based on acuity. The evidence is clear that for lower acuity cases, you want to put that behavioral health capacity as much as you can in the primary care setting, maybe even by the primary care team themselves. Whereas for high acuity, maybe it makes more sense to put that in a behavioral health setting and bring primary care into that. Lower right-hand corner, you cannot have individual docs trained in hospitals if you want to do this work. You need team-based care training. You need a broad definition of primary care competencies, and it has to happen in community settings. And then finally, in terms of HIT, we're going to hear from our experts today talking about the role of telehealth, the fact that this has to be across settings, and that it has to incorporate data from a number of different sources and health information exchanges so that we can get a true picture of the patient's health. I want to close by just note how important this is for California, and to appreciate all you folks for coming in, and particularly Blue Shield for organizing. One thing, innovation flows from west to east. I say that as an East Coaster. We look to you guys to help figure out what's going on. And the other thing I would say, it's sort of like the weather. It goes from west to east. So the other piece I'd say is you've got particular challenges. When in preparing for this, I learned that Medi-Cal itself, the largest payer in the state, has got fundamentally different financial flows for behavioral health and acute medical care. It's hard to talk about integration when your payments are not integrated. So in some ways, we have to work on these fundamental challenges. But we've got a really great panel that's set up here. I want to encourage all of you to pay attention to the blog that Shruti and I will be doing as a follow-up to this. And I want to repeat Shruti's urge that if you haven't registered, if you're on someone else's link, please register so that we can follow up with you, inform you about the follow-up pieces to this, and also the upcoming parts of the series. So look forward to the conversation from our experts here. Thank you very much.
At baseline, to just kick us off, Jessica, Gil, Nina, can we talk a little bit about, when we think about behavioral health integration as a concept, why is it so important?
I'll go ahead and I'll jump in. I'm Jessica with NAMI California, representing families and individuals through advocacy, education, and support. For families and individuals, when we are first, hit with a crisis, or we have a loved one or ourselves and we're just not feeling right, where do we go, right? This is always the conversation. And the first place that most of us turn is our general practitioner, our primary care. And so we really expect to get the treatment and the service that we need almost immediately. And when we don't, and we just get like a referral or a card or something, that is a wall, a literal wall that an individual or family member then has to jump over just to get into the first step of any kind of treatment. And we also know that families and individuals who don't seek care early have an 8 to 10 year treatment gap. That could easily be reduced if we can just flip the triangle, so to speak, and do some prevention and early intervention starting at the primary care setting. We know that COVID-19 has increased the urgency for this much broader way of accessing treatment. And we know that the increase for mental health care is from 1 to 10 to 4 to 10 adults reporting symptoms of anxiety and depression just in the last couple of years. When the Kaiser Foundation did the report. So it's so important that behavioral health and primary care are integrated, not only for so many reasons that all the other experts are going to be talking about today, but most importantly, for the patients and their families.
I'll add into that. I think, just to contextualize, our work in the context of this discussion. So Rubicon MD started out as a business providing e-consults, text-based opinions to support primary care across 100 and now 40 specialties and subspecialties. So we were bought in from like our inception that like primary care should be the foundation of a well-run healthcare system, and that you need to provide the right support to primary care to be able to actually enable them to quarterback the patient, care for the patient. So like that was our kind of foundational kind of thesis on which we built our business. And just over time, we just kept hearing more and more questions about the behavioral mental health side. Just, do you guys have support? How deep is it? What access can you have? And we started to dig a little bit there, and really two things emerged. At the micro level, when we talked to clinicians, they just continued to kind of echo this sense that they just felt uncomfortable asking questions about behavioral mental health, because if they got one, there's just not, the training isn't there, and there's not the same level of comfort for a lot of clinicians. But two, even if they got the answers to those, they didn't have access to the resources to be able to actually act on those things. So depending on what I find out, I actually still don't know how to help this patient because I don't have a lot of resources there. So we kept hearing that at the micro level, and then at the macro level, we have all the data that I think everybody has, which is that, patients with behavioral mental health, conditions end up costing 3 to 6 times, that of other patients. And it's always tied to the fact that it's poorly controlled behavioral mental health. And so we can't, as a business, and we couldn't as Rubicon MD say we're supporting primary care if we didn't launch a direct offering tied to behavioral mental health support. And so 2 years ago, we launched a collaborative care model to be able to provide direct support to the primary care and to help them to scale their capacity there. And we had to, essentially, to be able to deliver on our promise to the patients and to the primary care clinicians, we had to create a deeper set of support for behavioral mental health conditions. And so I don't think you can't say you're treating the whole person if you're not providing that. And if you're providing support on the specialty side, you have to provide, I think, that dedicated access. And it has to be integrated into primary care, because most patients, if they make it to primary care and they've got a mental health issue, they're not going to make it to the specialist. And so you've got to arm the primary care to be able to address and treat the issue there, and then to help to guide them to any other resources they need.
Well, as I thought about this question, I very much thought about I'm so glad to hear Jessica and Gil bring up these themes, that the idea of asking the question of what does behavioral health integration mean? This is something that makes complete sense to us as people. And we built all these ridiculous, complicated systems to actually disintegrate them. And so then we have to have panel discussions like this to remind ourselves and to remember the pieces of the system that really naturally belong together, right? Like within each of us as a person, our mental health and our physical health are totally intertwined. And so of course, our care for those two pieces of ourselves or those conditions should come together. So for me, as a physician, I did my medical training when the AIDS pandemic was really just ravaging our communities. It was everywhere in training. It was in our ambulatory clinics. It was in our hospitals. And so for me, as I was learning, the idea that people's overall well-being drove their health behaviors, and then their health behaviors drove their health outcomes, it was just integral to my whole being as a physician. And over the years since then, we've gotten really conclusive evidence, like about the ACE studies, the adverse childhood events, that the experiences you had in your childhood that affect your internal landscape will actually directly affect your physical health as you age. We know that's true now. In my practice, like it made not a single lick of sense for me to like carve out anxiety and depression and other common mental health disorders in my treatment of patients, away from the physical health disorders I treated. It's not good for patients, as Jessica said, right? It's inconvenient at the very least. And at the worst, it creates stigma and the idea that those mental health conditions are somehow different or worse or shouldn't be talked about compared to the physical health conditions. And I think as a primary care provider, it actually interferes with my ability to treat their physical health conditions, as Gil was saying. If you don't address mental health, it's more costly as a patient, because everything gets more confusing and disintegrated in the system. It also, when you think about longitudinal primary care, not integrating behavioral health into what you do as a primary care provider, it interferes with the relationship that you build with patients that enables that kind of continuous whole person effective primary care over time. I just want to take one more minute to talk a little bit about an experience I had as a primary care doctor. It was one of the most moving treatment experiences I had in my career. There was a young man I took care of who'd had a blood clot in his lungs. And like, understandably, this was just a terrifying experience. It was really a life-threatening experience. He could have died. And afterwards, he was understandably quite anxious, and he was in treatment. He had insurance, he was in therapy, he had a supportive family, but the anxiety was still really paralyzing for him. And each time he had a new symptom, it raised the fear for him that like, this could be another blood clot, I could die, what's going to happen? So what we did, we sort of loosely, in the context of just my primary care practice, formed a team where his behavioral health care was integrated into his medical care. So I would monitor his medicines and evaluate his physical symptoms, and then I would communicate with his therapist, and then I could integrate the sort of perspective of what was happening in his therapy back into his medical care so that it all made sense to him. And this integrated care allowed him to get really truly back to health. Like, he was protected from a future blood clot from a medical perspective, but he also got to a place of significant mental health growth, by putting this all together, and it set him onto a really much better path in his life overall. This is the thing though, like, I did this by running late every single time I saw him. I'd run way over my appointment times. I had to make calls during my lunch or after hours. The system was not set up in any way to encourage me to do this. So what I envision as I go through my work here at Blue Shield is, how can we create a system where that kind of care is the norm, and we actually support patients and providers to enact that system together?
I love that. That's a great way to transition to also our next question, which is, in our increasingly digital world, what role does digital health really play in expanding access and supporting behavioral health integration? And would love to hear from anybody who wants to comment, but Kern and Jessica, I feel like you probably have some strong viewpoints on this.
I do. I can certainly kick off, and Jessica would love to hear your thoughts as well, and really appreciate the comments just before here. I mean, resonate deeply. And there is a massive imbalance between the demand for mental health care and the supply of providers in this country, and in California in particular. And so, that was true prior to COVID, and it's doubled, I think, as Jessica, you were describing, during COVID. So these problems have only gotten worse. It was wait times of weeks, if not months, in certain rural parts of the state, for sure. And that's even worse for specific groups, communities of color, adolescents, other populations where it can sometimes just feel impossible to get access to care. So primary care plays such a critical role particularly in identifying those needs. And as we've talked about, this disintegration has really caused so much friction for, at the end of the day, for an individual, for a consumer, for a member or a patient to really get access to that care. And we don't have enough time or training or resourcing or payment to support primary care to do this effectively, right? We haven't historically been able to. So I see the role that digital and virtual plays as really being an augmentation to this system, not a replacement for the system, because the existing system is playing a critical role and it's vastly insufficient, right? And so I think there are a couple of fundamental changes that we have to make, one of which is really just as a starting point, you don't need to have a diagnosis to get access to care. And that the traditional systems, even in primary care or otherwise, are largely built around needing a diagnosis for depression or anxiety, when the reality is there's a vast majority of people who might just not be quote unquote feeling well, might have sleep, relationship issues, workplace stress, maybe using lots of different euphemisms to talk about mental health care, when in fact there may be underlying actual core issues that need to be addressed. But it starts with prevention. And it starts, I think, first and foremost with figuring out kind of lightweight, low cost, easy to access ways where technology can play a really critical role in unlocking that. We think we think about that a lot, at least in historical Ginger, and now as part of Headspace Health, through by offering behavioral health coaching, meditation, mindfulness content, kind of other lower touch, lightweight on-ramps to getting access to care for people who would have traditionally just been locked out of the system. And then it's like we're talking about here, it's empowering the existing care network, therapists, psychiatrists, to actually use technology to be able to actually have more scale and be able to support more people with potentially the same resourcing to start to get some more leverage, and stepping members up, stepping members down, integrating them in a team-based collaborative care model like we're talking about. But then fundamentally, and I think finally, it's really, the technology is really more a mechanism to start to unlock affordable access for far more people. And I think that's really the big opportunity here. And we'll talk a little bit more about payment reform and payment innovation, but it's a combination of great technology, new care models, and starting to actually cover new kinds of care, like coaching and content and other resources that have traditionally not been considered part of mental health, as a way to really unlock access. We actually recently kicked off a partnership with Blue Shield of California earlier this year, and have a number of other partnerships with health systems and health plans where we've really been focused on that. It's still the early days for sure, and we're learning a whole lot about which populations these sorts of approaches might work well for. But I think that's part of where I'd love this conversation to go, is to start to think about what's the broad ecosystem within which this is operating, and the ways in which non-traditional forms of care actually can be included as part of this discussion.
And just to add to that, I think that you're absolutely right, Karen, in that especially during COVID, we have seen kind of that mild to moderate, like my sleep, I'm stressed, but those are the early signs and symptoms that could totally lead into something much worse. And it also cannot lead into anything that's much worse. But the point is that there needs to be tools that anybody can access where they're at. I think that the biggest conversation that we need to have when we talk about digital and telehealth is the digital divide, and making sure that there's access to these incredible tools for everybody in California. And I think that that's one of the biggest challenges when we talk about telehealth, next to the payment piece, but there has been some advancement in payment of telehealth, especially during COVID. We at NAMI California worked on a bill that was passed to extend the telehealth payment so that people can have access to telehealth and providers can get reimbursed for that. We know in Medi-Cal land that there is some movement in No Wrong Door, and that telehealth is a piece of that as well. I think the overall picture should always be, as we're all sitting here in whatever hat that we wear, is that somebody's journey with behavioral health, it doesn't always look the same for everybody. So you can't just have a single pill that's going to make somebody get better. Behavioral health is a concept around treating the body, treating the mind, and those interventions are very different. And there has to be accessibility to all the treatments that are available, including telehealth. Just a quick anecdote story, stigma is huge around accessing behavioral health. Walking into an actual brick and mortar behavioral health clinic, I would assume that, and I don't have the numbers, but that more than half of the people don't even do that just because of the actual physical barrier of opening the door of a behavioral health clinic, right? And so having different ways for an individual to either talk to their primary care, to access an app that provides them with simple things like meditations, how to improve your sleep, but that can go one step further, that Headspace does and does the coaching, and then that can be taken back to their doctor. It is not just a one size fits all, unfortunately, and that's what makes it, I think, a little bit difficult and more labor intensive, so to speak, when we're trying to talk about primary care integrating with behavioral health, with apps and digital, focus. But if a patient and or their family could even just pick up the phone, can turn to their phone, their physical iPhone, and access an app that could then be integrated into their treatment plan, we can go leaps and bounds in getting people access early so that we don't have to have the mental health crisis that are so much more expensive, as Gil had mentioned, that we can really save money and save lives. But we have to make sure that when we're talking about digital health, we have to recognize that not everybody has access to this. And that should be a part of our conversation and a part of what we're advocating for and what we're doing when it comes to payment reform, is making sure that no person in California can go without the treatment that they deserve where they deserve it.
Shruti, can I just say one thing? My experience in the pandemic was that when we had to turn on telehealth, we just did it. And it was way more acceptable to people than we thought that it was going to be. And that what in fact was getting in the way were structural barriers that we had created to allow it to happen, primarily payment, right? There was no parity for payment for providers to do their visits by virtual care. So they forced people to come into the office so they could get paid. But other barriers like access, if people don't have the digital tools to get that video connection with someone, we have to find a way to put those tools in people's hands, because what we learned over the last 2 years is that both providers and patients are totally willing to use those tools in a vast variety of settings, more than we ever anticipated.
Yeah, that's a great point, and it actually is a great segue to the next question, which is around when we do think about the payment models that are employed, how and why are they important to supporting that integration and kind of removing those barriers that you just mentioned, Nina? Maybe Gil, we can start with you on that one.
Yeah, I think you kind of led with it in the intro, Shruti. I think it's important to think about the fact that people every payment model is set up to charge for like a specific set of services. And it's like you're trying to carve up a single person into like discrete services. And to some extent, you just need to be able to treat the whole person and integrate care, and payment models explicitly work against that. So, we work within a lot of value-based organizations. Our parent organization, Oak Street Health, owns primary care centers that they support just in a value-based way. And the reason they do that is because that's how you are best able to come up with the best approach for that patient that is tailored to them, without having to worry about which specific codes you bill for which specific, sets of things. That's, obviously ideal state. We're not there yet. But even when you get to that state where you're truly thinking about population health, you still have to consider the other side of how much of providing credit for these services that are delivered digitally in these innovative models. And the reason being is that a lot of how people think about whole person care and the cost of managing a patient when you're taking on risk is by building up the cost of the services that it's going to take to manage them. And so if you're not looking at digital health and telehealth interventions as a discrete service, then you're not including that in the cost to manage the patient. So it is still important that there is reimbursement, and that, in California, we spent a lot of time with folks, and I think Blue Path has as well, to make sure that e-consults had coverage. Collaborative care has models have a code, and I think it's still very important to have that, because that's what feeds into the other side in the equation to make sure that you can deliver value-based care with the right economics. The one other thing that I would say that I think what came up in some of the discussions that we had before is that right now payments are so skewed towards specialty care. And I think Nina brought this up, but all of these things take additional time, and they don't just take additional time from the PCP, they take additional time from the specialist, they take additional time from the PCP. And so being able to not just create the space in an organization where like you can spend 30 minutes with a patient, you can do other things, but to also credit the primary care for that. And so a lot of what we did when we were dealing with Medicare around e-consults was to make the case that it's not just the specialists who should be paid, but it's as important to pay the PCP, because when the information comes back, that creates work that they then have to do. It takes time. And that's what primary care wants to do, that because they want to manage the patient, but you can't just shift costs and just pay more to specialty care, which is what we've historically done, and then ask primary care to do more. Like that's basically how all reforms have worked. Is primary care should be the foundation. We should do more there. We're going to build ACOs around primary care. We're going to do more, and then we're actually going to then shift and figure out how we pay specialists more in these, in academic medical centers, et cetera. So I think as we're shifting to value-based care, I think we have to make sure that we're also building in the credit for primary care so that they can actually have the coverage to do more.
I think that there's just old sayings that come up when you think about this, right? Like time is money and you get what you pay for, and those kind of things, right? But I think when I was talking earlier about what I had to do to get that outcome with that patient of mine, how can we pay for those behaviors that drive that kind of care? That's why payment models matter, because they drive behavior. And so, we know nationally, primary care is totally under-resourced. It's stretched super thin, and it's not just the primary care doctors, it's their staff too. Some of these kind of interventions require medical assistants doing different things, or LVNs in practices making different kinds of phone calls. And that they're all practicing in this system, or mostly practicing in systems that reward the volume of services, just do more, do more, do more. And so resourcing for integration means that we allow for ways for them to build teams and financing those teams. It can be collaborative care that's at a distance or co-located. As Gil is saying, it can be e-consult that supports the primary care team and actually doing the work. But it also means paying the primary care teams to really allow for this to happen. So if you think of a therapist who's trying to establish her new practice, what's going to motivate her to establish that practice within a primary care practice rather than in a carved out private practice where she gets paid, cash pay? She can demand cash pay from the market. What are payment models that will allow for that kind of integration? And how can we also pay the primary care doctors and nurse practitioners and physician assistants so that they can slow down and really think let me ask about mental health symptoms. Let me screen, let me assess, let me treat, and then let me reassess. It's all those steps have to happen in order for them to know if their treatment is succeeding or if they need, if they need to refer out. I think the one other thing I want to say is, this can't happen from one super innovative program like Oak Street or, one insurer trying to, do the right thing and provide for integrated teams. We have to find a way to get to multi-payer alignment, because practices can't take the risk of doing things differently unless they have a reasonable guess that they can achieve financial stability under these new models. So Blue Shield is working here with Integrated Healthcare Association and Purchasers Business Group on Health to convene 10 of the largest health plans in California to try to move towards voluntary participation in advanced primary care models that, that provide for behavioral health as well, behavioral health care.
First off, I love this discussion. I don't think I realized just how critical payment model innovation and pricing flexibility was to care model innovation and all of the work that we're fundamentally doing. In so many ways, historically, so much of what we've had to do is fit into a box because that box was painted a certain color or a certain shape and size instead of focusing on outcomes. And I think as Gil and Nina have both described so well, like this is a chance to really move beyond the, at least in the, for instance, in the therapy side, the 60-minute consult, right? To non-traditional models of care. I think Jessica, like you described so well, what works from whom, when, and how is so different depending on where you are in your care journey. So to think that just a handful of codes is actually just going to cover this and a handful of kind of intervention models, it hasn't worked. It's not going to work. And unless we fundamentally change that, we're going to keep getting the same outcome. And so what I think we've been really excited by is both through some partnerships with some of our employers historically, but increasingly now with health plans, starting to get paid not per transaction, but really for an episode of care or even on a PEPM basis for a period of time, to be able to then have our care team, coaches, therapists, psychiatrists, the underlying kind of data science and infrastructure, figure out what's needed. And for some people, it might be the combination of a coach, maybe some sleep hygiene meditations, and maybe they need actually a therapist as part of their care team, or they may even need meds. But that combined approach or set of interventions could actually get someone better far faster than having to do this in a sequential way. And I think a key part of that, Nina, as you were describing at the end there, is upskilling new kinds of workforce, because the reality is our existing care providers and care infrastructure are just insufficient. And so just like with NPs and PAs historically within primary care, I think there's opportunities within mental health care to start to introduce new levels like coaches and others that can be part of that care stack and actually start to figure out ways to pay for those, that time and those resources, because it's more efficient and oftentimes it's actually better outcomes. And so I'm really excited about, I think, what the conversation we're starting to have and really actually getting this sort of group together, because it's not any one of us that's going to by any means move this needle. It's a combined effort and a whole bunch of experimentation to actually get us there and figure out what works, because we have some ideas and there's certainly some early data. But no one has the silver bullet here.
Y'all have made some really excellent points. But really, what's the call to action today? If each one of you, lightning round, can talk about what can folks on the line do? Maybe Jessica, we'll start with you.
Well, 1 minute is not enough, but I think that for those people who are on the line is to remember how important any of our care is to the actual family and the individual. So you guys all got into this work because you're passionate, you're smart, you have a personal drive, but at the end of the day, the treatment is affecting the individual and their families, and what's best for them is what we need to really focus on.
I can dive in. I would just say we shouldn't be confined or constrained by the models that we've seen and known historically. Like, the future can look very different than the past. And there's an opportunity, like we know that the way things work the way things are doesn't work. And I think we can reimagine the system. And then, just a plug for the importance of value-based care and being able to support kind of that reimagined system.
Great suggestions. For me, I think that the theme echoed here is really payment for preventative support, because at the end of the day, that's the only way I really think we're going to stem the tide. And I thought there's a lot of really great comments and questions in the Zoom chat here, particularly around equity. And so I think that's an important component. I think it's been threaded throughout a lot of our answers, but making sure that we think about potentially customized or unique solutions depending on the specific needs of a certain group. And so a lot of what we're talking about may need to be fine-tuned depending on specific populations who really, because of technology or because of other research, language or otherwise, won't have equivalent access to care.
And I guess my call to action, and I can say this partly because my amazing colleagues have called other really super important things to action, is for me, it's about the workforce, that we have an inadequate and burnt out workforce, and that people are demanding like a totally reasonable demand for compassionate and equitable mental health care. And we can't provide it because we don't have the workforce. And so like training is great. We need to train more people, and training should include practicing in multidisciplinary training sessions so that people understand the benefits of that model. But we also really have to allow current existing primary care practices the time and the payment that they can, so that they can do everything they can to screen for symptoms of mental health disorders and treat everything that they can within their capacity that they're professionally and safely capable to do. And I believe that if we do this right, it actually will lead to an enhanced sense of purpose for people practicing care. And it's a great antidote to burnout.
First question for the group here: how can patients and families become part of the care team? And what is the role of community in supporting patients between visits with the care team? And this one, Jessica, was targeted to you, but really anybody who would like to answer.
Yeah, what a great question. You know, we've been in California, especially been talking about the peer workforce, right? And peers include families. When we hear that word peer, clients and families of both adult and children who might be experiencing behavioral health issues. The biggest thing that we can start to do is really focus on families and individuals being a part of the care team in a significant way, right? We know that 90% of the time, again, I know I'm dealing with a lot of very smart medical people. When I'm saying 90%, I'm saying anecdotally 90%, right? No research behind it. But 90% of the time, we are with our loved ones in the family, in the community setting. You know, very, very small amount of time are we in the doctor's office, in treatment, able to get, you know, whatever we need from digital. And so it's so important that families and individuals are not only trained, and we have programs through NAMI, of course, that are training families and individuals to be peer support counselors, whether it is to help somebody who is coming out of inpatient and moving in back into the community, whether it's a family member who's had their first mental health crisis with their loved one and they are, you know, in the emergency room. We are experts out of our own experience, and that alone is something that a book can't teach you, right? And so we have to also start thinking as a community, how can we integrate families and individuals who provide those support groups, who provide those psychoeducation classes, and are really there to support their loved ones? How do we make sure that not only are they a part of the treatment plan, but also how are we reforming payment to include these sorts of community-based models that, you know, can fill in kind of that Grand Canyon of a gap between treatment and the kitchen table.
So just to tie on to that, I think one of the things Gil said is like, we shouldn't have needing a diagnosis as the barrier into getting treatment, right? So if you want to integrate the parents or the spouse or the siblings of a person who's in mental health care, how do you bring them in for a session? Because it's not their diagnosis, right? That's silly. That's just silly. We need to find ways to remove barriers like that. Those are like, we got to look at, I think, Gil, you're saying like, let's reimagine this. Like, if we got this thing out of the way, what would we be able to do? And I think we have to start pushing and asking those questions and keep asking them till the people that can move those things out of the way do it.
I'd like to sort of expand the lens from what Jessica was talking about there and talking about the community portion of this. I think that it's really important to get the family voice and the community voice, not only in terms of the treatment, but in terms of the governance, the prioritization of decisions that are made, and the policies that are made. So if these are, look, this is about, a lot of this is about power, and those entities with power don't necessarily relinquish it. And so if we need community input to change, if we're going to change that, we need community input. We need political will, whether that's at the practice level. And I think the community health center model of community governance is really interesting to look at, to surface what needs are, but also in the policy making. You know, in my opening remarks, I was talking about it's pretty hard to integrate Medi-Cal when the payments are going in. Pretty hard to integrate behavioral health and acute medical care and Medi-Cal when the payments are going in different ways. That's not going to change magically. that's going to take community input and gathering to create the systems that will make the kind of care we're talking about more possible.
And shifting the question, piggybacking off of this question, but shifting it a little bit, we had an audience question around building on the idea that patients and families play an essential role in the care team. So should payment support family members who are supporting their loved ones? So for anybody who'd like to answer that.
Yes, I mean, NAMI is advocating for that, of course. And like I said, with the passage of our peer certification, at least the Medi-Cal model, it's very different. There's a big gap between public and private insurance and how people are paying for behavioral health. But it needs to be, to Nina's point, it needs to be across the system, and it shouldn't be these siloed, how do we get these things paid for? But it is something that NAMI is continuously advocating for. And we believe 100% that families and individuals should be not only a part of the care team, but should be paid for that as well.
I see you coming off mute, Karan. Did you want to say something?
No, just major plus one to what Jessica described, both at the family level, and I think it's implied when we say patient, but at the individual consumer member themselves, being able to empower them to advocate for themselves, to actually leverage resources and figure out how to pull together a set of resources. We've historically had this top-down paternalistic view, and at the end of the day, we need to invert that pyramid. So I completely agree.
Love it. So another question we had was elaborating on the digital divide. So how can we better reach underserved populations and other folks who may not have equitable access to behavioral health services, particularly those who are not comfortable with telehealth?
I think there's a few things that are important to consider. So I do think the digital divide is like foundational to the challenges that we face in reaching those groups. But I think it's just like one of several. We talk a lot, kind of on the RubiconMD side about the social determinants of telehealth. One of them is, yes, access to Wi-Fi, access to a device, but they're all this like same ideas as when you think about the social determinants of health. If you want to do a telepsychiatry visit and you live in a 1-bedroom apartment with 3 generations sharing the apartment, you are probably not going to find a quiet, safe space to be able to have that telepsychiatry visit or teletherapy in that appointment. And so there are all these other environmental considerations that kind of play into it. Like, food is a similar, like there are a lot of different pieces and a lot of different elements that go beyond just saying you need to enable people with Wi-Fi. And so I think what we need to do is there are a few things. So one is to start to meet people where they are. And so there are people who are in the community who know how to engage people and who can get them access to services. And so this idea around digital health, that if you build it, they will come, has historically kind of been the way we've thought about it. But a lot of these services, and I'm sure Karan has thought about this in greater detail, but like a lot of these services have to be tailored and set around where the patients are, how they're going to interact, and really think about them as the kind of center versus, kind of where they have to go. So there's not this, if you build it, they will come element. And then I think the other thing is, for a lot of these underserved communities, people think about the patient side of the equation, but they don't think about the provider side of the equation. And a lot of these communities are supported by community health centers and federally qualified health centers. And one of the things that we saw through the pandemic was we see kind of all ends of the or sides of the spectrum. We saw a lot of groups and organizations that went to 90 and 100% virtual in like a matter of a week or two. Then we saw a lot of other organizations that struggled to get there, and halfway through the pandemic, we're trying to get patients back in person because the payment pieces there kind of necessitated them to see people, to be able to start to bill higher codes, to be able to become, financially sustainable again. So it does come back to that payment piece. And these are all organizations that want to do the right thing. But even beyond the payment, those organizations didn't have the same infrastructure to be able to see patients. And so if you want to have those visits, people who are in the community who know those patients, who are the trusted providers, primary care and therapists, they also need to be armed with the technology and resources and trained on it. Like there's a lot of things that are very different about the training that it takes to see a patient virtually. Like if you see somebody in the home, there are a lot of things that you're going to see and interact with you or in their environment that's very different than seeing them, in an office. So I think even the training and that has to be thought of differently.
Gil, can I just add one quick thing? I love that summary. I think it's a great overview. The one thing we have found, I know we've been talking specifically around telehealth as it relates to video visits, but the reality is we've seen actually that text-based interactions are actually a really powerful barrier lower or stigma remover, if you will, because in that exact scenario you've talked about, we've seen this with actually a lot of groups that we're working with, being able to then text in that scenario in a very private setting actually allowed for a different kind of engagement. It's not a replacement for the telepsychiatry visit, for instance, but we've seen that actually is really powerful, particularly as we launched Spanish language support this past year. And to your point, both recruiting providers that are culturally competent, training, and then changing messaging upstream to maybe recruit those members to access that care. So I think I loved your description of the social determinants of telehealth. I think that's a great way to put this. And there are a lot of different ways I think we can start to innovate on the engagement model to unlock access.
Huge point. The only thing I would also, sorry, I didn't want to, I also think phone as well. I should have think of text.
Oh, for
phone,
sure.
Like we shouldn't think about it as a single modality. So couldn't agree more.
And I think adding to that, like, let's not forget the brick and mortar places, right? Like, I think one of the things we have to do is ask people, like, where would you go when you're feeling bad? There's if you live in a crowded house and you don't want to talk about what's going on with yourself, there's other quiet places that are now underutilized. Libraries, right? Like, could we repurpose them with quiet rooms for mental health care? Like, I'm sure there's voices in the community that would tell us exactly where we need to put those services and have access, in community-based points. So I think more of that is going to be key to moving forward.
To reference what Gil said earlier, reimagine the system. And I think that is the biggest point if I had to summarize all of what we talked about. We are at time, but this was a great segue because our next in this 3-part series is going to be focused on payment and social needs. So again, if you did not register for this event, please do so. We have your email and we can, one, give you the recording. We can give you the summary blog that Chris is going to be developing from this event. And we can invite you to the next in this 3-part series that's on social needs. But to all of our panelists, thank you so much for being here today. We really appreciated your insights. And for the audience, we appreciate you so much as well and are looking forward to seeing you again in a few months at our next event. Thank you.